Satuan gol portan. Product chicken sa pagdilitin ko.
Now for that, washroom logic yesterday. What's the problem? What's the problem?
Lakshmi, what if Vijay Pindi?
இது இங்க கீழே அதாவது ஆஃப் பண்ணது. இது என்னது?
Trouble shoot, sir.
Trouble shoot தான். ரெக்கார்ட் பண்ண முடியாதுல்ல? நான் என்ன ஹோஸ்ட் ஆகிட்டேன் சரியா? No more fight. Good morning.
Good morning, sir.
We had actually discussed about echogenic kidneys in a case of the week. You remember? What was the focus on? Genetic what? What was the condition or the genetic condition that was the prime focus of the presentation? Anybody remembers? 17q12 12 சொல்லணும். Qக்கு அப்புறம் வரது ஒண்ணுனா சொல்லணும். 12 microdeletion syndrome. Subsequently, we had a more presentations, but now we are moving into kidneys from CNS. So we'll revisit echogenic kidneys during the journal club. Okay. Simply because some authorities or experts, okay, refuse to accept echogenicity, alteration of echogenicity as a pathological entity in the kidney. So they simply resist accepting that, at least in public fora where I have asked. But there is mounting evidence, and we ourselves have seen its association with genetic abnormalities. Okay. All right. Sadhvi.
Good morning, everyone. Today, I'll be presenting an article from Frontiers in Genetics, which was published in 17th August 2023. The title of the study is A Fetal Hyperechoic Kidneys, a Cohort Study and a Meta-Analysis. This was done by Wei et al. At Harbin Medical University and Harbin Red Cross Central Hospital in China. So coming to introduction, the congenital abnormalities of the kidneys and urinary tracts, CACUT, is the most common fetal structural abnormalities, which constitute 30 to 50% of the prenatally diagnosed malformations. So the prevalence comes as around 4 to 60 per 10,000 births. So fetal hyperechoic kidney may be transient in pregnancy, or it may be an ultrasound manifestation of CACUT or some other syndromes. So it is detected approximately 1.6 out of 1,000 scans done. So there are two types of hyperechogenic kidneys. It may be isolated or it may be associated with other anomalies also, which is called as non-isolated hyperechogenic kidneys.
So when you read articles from Chinese background, no, you should give some allowance to the English words also. So it's not a type, no. There are two situations, or for the purpose of analysis, there are two categories. So
Yes, sir.
some allowance is allowed. Okay.
Yes, sir.
Very difficult for them to communicate.
Yes, sir. So hyperechogenic kidney may be a first indicator of an underlying kidney disease, which can clearly present in the third trimester or after birth, such as renal dysplasia, fibrosis, interstitial infiltration, tubular or glomerular dilatation, and microcyst. So implications of these findings are less clear in the prenatal period, making the counseling and planning and management extremely challenging in the prenatal period. So differential diagnosis of isolated hyperechogenic kidneys has been given as autosomal dominant polycystic kidney disease, autosomal recessive polycystic kidney disease, congenital nephrotic syndrome, renal vein thrombosis, and obstructive uropathy. The differential diagnosis of non-isolated hyperechogenic kidneys has been given as aneuploidies, mainly trisomy 13, fetal infections with cytomegalovirus, Meckel-Gruber syndrome, and other renal ciliopathies, monogenic disorders associated with CACUT, Beckwith-Weidman syndrome, Perlman and Simpson-Golabi-Behmel syndrome. In this article also they have
Beckwith-Weidman, Perlman, Simpson-Golabi-Behmel, mouthfuls are all what? They can be grouped under one term.
Overgrowth syndrome.
Excellent. Who was that?
Guhapritas.
Okay, Guhaprita gets a Amazon gift voucher. So there are overgrowth syndromes.
Yes.
So when the organs, visceromegaly happens, then also the kidney can look bright. Okay.
Yes, sir. In this article also, the cases which they have analyzed, they have also divided the etiologies and told which is the most common from first, second, third, and fourth and other. We'll see that in the later slides. So the purpose of this study was to determine the positive rate of the prenatal tests which can detect chromosomal and monogenic etiologies in hyperechogenic kidneys and to determine the perinatal mortality and related factors in isolated hyperechogenic kidneys and non-isolated hyperechogenic kidneys, so that the clinician can determine the prognosis of the fetus and provide accurate counseling for the parents better. So coming to the type of study, first they did a retrospective cohort study from the sample collected from their hospital, but as the sample size was less, they also undertook a meta-analysis of 21 studies. So first, coming to the materials and methods of the cohort study, 3,995 cases of prenatal diagnosis from Harbin Medical University and Harbin Red Cross Hospital, examined from January 2017 to December 2022, was taken, out of which 251 cases were found out as fetal kidney-related abnormalities, out of which 25 cases had fetal hyperechogenic kidneys, out of which 14 cases were isolated hyperechogenic kidneys and 11 cases of non-isolated hyperechogenic kidneys.
Okay. Here, what does that 4,000 odd cases represent? There. So you mean to say in a big medical university for how many years? 5 years, only 4,000 cases examined in China? What is that?
That is the cases where all anomaly
Referred for a suspicious diagnosis of anything, or is it just routine?
in which they had found some abnormality in these cases.
Okay.
And out of that, they selected the renal abnormality.
Okay. So which means that they are the fetal defects cases, correct?
Yes, sir.
So 4,000 cases of fetal defects found by prenatal diagnosis, of which 250 were kidney. Is that correct?
Yes, sir.
Have they explicitly mentioned
what defects?
They have told that this is a group which had a defect, anomalies prenatally detected, or
So
they are all referred for routine scans, not routine scans.
Routine scans.
Okay. Sure. Otherwise, the previous usage of the term prenatal diagnosis was when you had to do an invasive diagnosis. Okay. So they might mean that also.
Yes. So all patients, in the patients which they selected, all patients underwent at least 2 genetic tests. They were followed up by telephone within 6 months to 1 year of their EDD, including newborn survival and urinary status was asked about. And the conditions of the patients were recorded, and the results of the patient deduction and prognosis was statistically analyzed. SPSS 270 statistical software was used, and chi-square test was used, as these were categorical variables. But the sample size in one box was less than 5, so they used Fisher exact probability method. And P less than 0.05 was considered as statistically significant. So coming to materials and methods of the meta-analysis. So they searched in the Chinese language databases and English language databases using the words fetus, kidneys, hyperechoic, antenatal, prenatal, hyperechoic, and kidneys. So the data extraction was done by 2 researchers independently screening the literature, extracting and cross-checking the data. Differences, if any, was resolved through discussion or negotiation with third party. During literature screening, the title of the paper was read first, and after excluding irrelevant literature, abstract and the full text were further read to determine inclusion. So in case if there was not adequate information available, the original authors were contacted for information which were important to this study. So the data extraction included basic information of the studies like research title, the first author, published journals, the baseline characteristics of the research object, and further deduction methods. Key elements of risk of bias assessment was used, PRISMA and Moose guidelines. PRISMA's preferred reporting items for systematic reviews and meta-analysis, which is a 27 thing checklist, which can also help in data extraction, bias assessment, and reporting the meta-analysis. And MOOS is meta-analysis of observational studies in epidemiology, which is mainly used for observational study meta-analysis. So outcome indicators of the interest and follow prognosis was seen.
So how do we go about doing it? That is what they have told. Okay. So when you want to do a meta-analysis, think about the clinical problem that you are facing. So you see a baby tomorrow with, let's say, a thyroid swelling, and you want to know how to counsel the patient, or you want to know if there is a way to find out whether it is hypo or hypothyroidism, what is the thyroid status. So you know that there won't be any big series published, so you want to combine and see if the combined is better. So first fix up your clinical problem, think hard, okay, and then fine tune the problem, make it into a fine question, not very broad. Then you ask what are the information you would be requiring to answer that question. That's your Excel sheet. Understood? So prepare that Excel sheet first. Then you say, okay, in order to get this data from the existing literature, I need to search under these titles, under these keywords. Okay. So then you go and search, you will get a lot of papers, and then you have to go through these papers individually. Sometimes they would have done a different study, but in the keyword they would have put thyroid, thyromegaly, like that, because it comes in their study. But those things you can exclude, those which are not relevant. Okay. Then the relevant ones you assess for certain quality indicators. Whenever you do a meta-analysis, you should do a quality assessment also. How much is the bias? And once that is over, then you abstract, filter out the data and put it in your Excel. That becomes the overall data for your analysis. Understood?
Yes.
Up to this, it's systematic review also.
Yes.
Once you combine the data, you think they are combinable, there are relevant guidance for that, what all can be combined. Once you combine the data, then you can use statistical methods to analyze that data, and that is meta-analysis. Understood? So the saying goes, when somebody says the meta-analysis is there for me to tell, what you should remember, just because you show a meta-analysis does not mean that's the word from the Bible. Because meta-analysis is the result of what you put inside, no?
Yes.
Garbage in, garbage out. So if the studies that were included in the meta-analysis were all poor quality, the results also is poor quality. Understood? So remember that also. Yeah.
So the diagnostic criteria used for they also did a subgroup analysis based on the amniotic fluid volume, kidney size, and corticomedullary differentiation. So the diagnostic criteria they took was for polyhydramnios, amniotic fluid volume more than or equal to 8 centimeter, or amniotic fluid index more than or equal to 25 centimeter. For oligohydramnios, amniotic fluid volume less than or equal to 2 centimeter, or amniotic fluid index less than or equal to 5 centimeter. Hyperechogenic kidneys were labeled when the renal parenchyma was of greater echogenicity than the adjacent liver tissue. Renal enlargement was said when the kidney size was more than or equal to 2 standard deviations, or the renal volume was above the 90th percentile for the gestational age. Kidney reduction was told when the kidney size was less than or equal to 2 standard deviation, or a renal volume below the 10th percentile for the gestational age. So the inclusion criteria was fetal renal hyperechogenicity confirmed by fetal ultrasound in the second or third trimester. They included both singleton and twin pregnancies, and they included the studies which reported fetal, neonatal, and infant outcomes like termination of pregnancy, intrauterine death, and neonatal death. The exclusion criteria was reviews and case reports were excluded, animal research was excluded, and studies where there was no further testing or follow-up of the outcome was not there, those studies were excluded. So this is the studies. So records identified through database searching were 311 studies, and after duplicates removed, 272 studies were there which were screened, and 118 studies were excluded as they were case reports, meeting abstract, and review or meta-analysis and consensus. The remaining 154 studies, out of 154 studies, 133 studies were excluded as there was no health or clinical management outcomes mentioned, no further testing was done, irrelevant abstract and title, and animal research was done. So the finally included one was 21 studies in the quantitative meta-analysis. So these were the 21 studies which were included. So the quality assessment of these studies was done by Newcastle Ottawa scale. It assesses each study on 3 bases: assessment of the selection of the study, assessment of the comparability of the study, and ascertainment of the outcome of interest. So each study is awarded a maximum of 1 star for each item, but 2 stars can be given for comparability. So if a study has at least 6 stars, it is rated as high quality. So these were the studies which was assessed according to Newcastle Ottawa scale, which had more than 6 stars and were included in this meta-analysis. So statistical analysis of this meta-analysis was done by Review Manager 5.4.1 software. They analyzed the incidence of chromosomal and gene abnormalities, and odds ratio and 95% confidence interval of the different outcomes was analyzed. Fixed effect model was used if the p-value was more than 0.1 and I-square heterogeneity was less than 50%. Random effect model was used if the I-square heterogeneity was more than 50%. So heterogeneity is where we see a study variability. So initially they calculate tau square, it will tell how much do the effects differ. And then they do a chi-square test for this tau square value, which will tell whether this difference is real or not. So according to this, then an I-square heterogeneity is calculated, which will tell how much of the total variance is due to the difference between studies rather than the random chance. So less than 25% heterogeneity is low, and it is a very good study. And if heterogeneity is 25 to 50%, then it is moderate heterogeneity. And if I-square is more than 75%, then there is high heterogeneity, high variability between the studies. So the test level for the meta-analysis was set at alpha, which is type 1 error of 0.05. Subgroup or sensitivity analysis were used to deal with significant clinical heterogeneity.
So what they are telling here is, when you use different studies and then try to find their combined result, you should also know whether the difference in the results from each study is original or is due to the way the study was conducted. Okay, understood or not?
Yes, sir.
So that is why in the methodology you are supposed to write every damn thing. It's like a physics experiment, and if I want to do it again, I should know everything that you did, and then reproducibility will become comparable. So that is what they will assess. When the studies differ by their own methods, then it's too much of heterogeneity between the studies. So heterogeneity between studies. Okay, but when they differ not by much, then we can say, okay, so the studies were okay, but the results were different because of the originality, because of the variability in the biological outcome. Get it?
Yes.
So that we need to know before we combine studies. Okay, and once we combine, what do we modeling means what? Assuming that means you are trying to put everything into one pathway. If there is a echogeny, then echogenic kidneys, then most babies will behave like this. So that kind of assumption is called modeling. You are combining different studies, okay, and you will be looking into some factors. If the studies are all homogeneous studies, everything is together, everything looks alike, performed along the same line, then it's a nice homogeneous study. Then we can say, okay, what all factors that we are seeing, they are only going to have the effect on the outcome. So that means it's a fixed model. Okay, the effects are fixed. Unknown effects are not taken into account. Get it or not?
Yes.
But each study is done differently. We have only a few things common. We are not sure if other factors are going to take part in the outcome, what we are going to find. You are getting? Then we have to say, okay, we'll use the random model, random effects model in the statistical analysis. So that will, when you finally see the combined effect, pooled effect, it will differ between whether you used a fixed model or a random model. Understood? So this is the way you choose which. So this is why so much of effort is put into analyzing the quality of the studies first, and then we come to using the statistics. Understood? So how to choose fixed or random model?
So now we go into the results. First, we'll see the results of the cohort study. So 25 hyperechogenic kidneys cases were analyzed, out of which 14 cases were isolated hyperechogenic kidneys and 11 cases were non-isolated hyperechogenic kidneys. Now, 4 cases were excluded from genetic testing as they doing karyotype, as they were more than 25 weeks of gestation. So karyotyping was done in 21 cases. CNV sequence was done in all cases, and WES was performed in 5 cases where the karyotyping and the CNV sequence turned negative. In karyotyping, aneuploidy detected in isolated hyperechogenic kidneys was 18%, and in non-isolated hyperechogenic kidneys was 22%. In CNV sequence, pathogenic CNVs were detected in 29% of isolated hyperechogenic kidneys and 37% of non-isolated hyperechogenic kidneys. When WES was performed in cases where karyotyping and CNV sequence was negative, it came pathogenic in all the 5 cases, which were 4 cases of isolated hyperechogenic kidneys and 1 case of non-isolated hyperechogenic kidneys.
Now go back. So first KT, then CNV, and then WES, is it?
KT and CNV they did simultaneously,
Okay,
sir.
for all.
But in these 5 cases, there were additional findings like age factor, bilateral hyperechogenic kidneys, multiple abnormalities.
The
So they
WES one.
wanted to confirm, and then they did WES. And it turned out to be pathogenic in all 5 cases where CNV and karyotyping was negative.
Okay. So the indications for WES was simply not a negative aneuploidy or negative KT or CNV,
No, sir.
but presence of certain other factors.
Yes, sir.
Otherwise, their standard evaluation is up to CNV only.
CNV. They store the amniotic fluid, and later in that amniotic fluid,
Store DNA.
DNA, and later in that they perform.
I understand. So first step is
CMV. CMA.
Not CMA. They have done CNV
sequence.
Okay.
So now I'll be telling the tables of all the cases included, which I'll be consolidating later. But here I'll tell the 5 cases for which WES was done. In this case, the age of the mother was more than 35 years. Previous pregnancy was terminated due to pathogenic mutation of PKHD1, and bilateral hyperechogenic kidneys were there. And hence the karyotype and CNV sequence turned out negative. They did a WES, and the pathogenic variant of PKHD1 gene was present.
So this is like a known variant recurrence. So they have tested it again.
Yes,
no?
sir.
Sure.
In this patient also, karyotype and CNV sequence turned out negative, but the patient has bilateral hyperechogenic kidneys and oligo. So to rule out infantile polycystic kidney disease, they did a WES, and pathogenic variant was detected. And in the next case, again, the fetus had bilateral hyperechogenic kidneys. The gestational age was more than 25 weeks, and the family deferred chordocentesis, and hence they proceeded with WES, which turned out to be pathogenic for PKD1 gene. In this case also, there was bilateral hyperechogenic kidneys and no kidney-related CNVs were detected. X-linked ichthyosis was only detected, and hence they did a VES, which turned out to be pathogenic for PKHD1. Ma'am? No, ma'am. Antenatal only, ma'am. இதெல்லாமே prenatal. So these were the 4 cases which was analyzed with VES in isolated hyperechogenic kidneys.
Okay, go back. So the 4 cases, isolated echogenic kidneys, where the CNV and KT were normal or didn't explain the kidney finding. But clinically, one looked like ARPKD, one had a prior history, that is a recurrence in the same family, and one looked like ADPKD, and the last one was unexplained, but that also is ARPKD.
Common factor was bilateral hyperechogenic kidneys, which they have told in the list.
Yeah.
Coming to non-isolated hyperechogenic kidneys, in one case where the karyotype and CNV sequence was negative, they did a VES as the baby had multiple malformations, but the baby was terminated.
Yeah,
So
go
coming,
back. We need to see those numbers. So clinically suspected Meckel-Gruber and identified.
Yes, sir.
Okay. And then the rest were either T13 or 16 duplication, but that was a WUS. Okay, so other associated anomalies were there. So if you have other associated anomalies, you are likely to pick it up in the CNV, which is true, isn't it?
Yes. So they concluded that in all 5 cases of VES, no kidney-related pathogenic variants were detected in the karyotypes and CNV sequence, but it turned out to be pathogenic in VES.
Because they were isolated kidney issues.
Yes.
Okay.
So 2 cases of trisomy 21 was detected in isolated hyperechogenic kidneys, but as trisomy 21 can present with multiple malformations, they concluded that other findings may develop as the pregnancy progresses. Variants of unknown clinical significance was diagnosed in 24%, and there were 10 cases with no definite abnormality, which accounted to about 40%.
So we'll be interested in knowing about the 10 cases also as a postnatal outcome.
Yes. So coming to the etiology and statistics, now as we see, the CNV sequence detected more number of cases compared to the karyotype, and the CNV sequence detected many cases in non-isolated hyperechogenic kidneys than isolated hyperechogenic kidneys. The termination of pregnancy was done more in non-isolated hyperechogenic kidneys than isolated hyperechogenic kidneys. But all these tests were not statistically significant. This may be due to the small sample size, and hence that meta-analysis was done to further analyze. So the pregnancy outcomes were termination of pregnancy was done in 56%, out of which isolated hyperechogenic kidneys 43% were terminated, and in non-isolated hyperechogenic kidneys 73% were terminated. So the remaining 11 cases, one autosomal dominant polycystic kidney case was detected after birth, and there was no neonatal deaths reported.
ADPKD might have been the one they had shown before. So what it means is, if you go stepwise in this manner, in this cohort, about 40% after, if you exclude everything, ultrasound correlation, associated abnormalities, and the 3 steps of genetic evaluation. Okay. Also, KT not necessary, because I don't think they had found anything that would have been missed by a CMA. You can say that once everything is excluded, very high chance of good survival, close to 90 to 100%. At the beginning, you can throw a number like, if it's isolated. So go back. Hold on. Come back. Yeah. No, go back. Go back. Hold on. So if it is isolated, of the 14, 8 are going to be okay. Okay, that is after a thorough search by ultrasound itself. Kila, last one, survived well. 8 are going to be okay. Last one.
Yes,
Show the
sir.
pointer. Let me show. All right. So this 8 is going to be the survivors. So that means you have to tell the parents, no? What is the number that you expect? Okay. 8 out of 14?
Almost 60%.
60%. Okay. So what we quote in our clinic is 70%, isn't it? So something similar from our data. Okay. If it is non-isolated, anyway, it's not a good prognosis. Only 3 will survive, and we know something has to be there. So we are more interested in counseling for the isolated ones, which means how far will you examine to know if it's isolated or not? And what would be the most challenging examination? Huh? Hmm. So you will examine, see, they have given certain things, no? Go back. Yeah. See all these things. So most of the things will be covered by your extended protocols. When you see an abnormal baby, then you will cover. But you should have that in your mind when you are examining. Okay, this is echogenic kidney. Now I am going to examine in detail. Polydactyly will be very challenging. Yesterday we had a case, no? We had reported echogenic kidney, but autopsy, there was polydactyly of only one side. Can be very challenging if you are just, baby keeping the hand somewhere. So carefully you should see. Carefully you should see for posterior fossa abnormalities, cardiac. Understood?
Yes, sir.
CNS. Yeah, Vector. So be careful. Okay. South Pole. So then it become. So that is why when you have a finding, immediately close it. Not immediately close it. Finish your routine protocol. Close it. Don't end the exam there. Bring her back again. Okay. Think about it. What all I should do for that particular. Let me examine once more with the thought in mind that this is all what I want to seek and find. Get it?
Yes.
Then only the examination becomes highly accurate to say it is isolated. Understood?
Yes, sir.
See, they also had one 17q12 deletion. Enhanced echo in both kidneys. Sir. Okay, go. So the counseling mainly depends on how extensively you have scanned in the first place. Based on that only, you're going to throw a number and ask them to undergo amniocentesis or not, because the parents like to know what is the number before they undergo the next level of testing. Okay, so that's very common for them to know. Ask. So you should be able to tell. If you test and everything comes out well, it's going to be a very good outcome. To say that, you should have examined the fetus well. Okay.
Yes. Now coming to the results of the meta-analysis. So they analyzed each genetic testing done. So positive rate of karyotype in non-isolated hyperechogenic kidneys was analyzed in 6 articles where 91 fetuses were involved and number of abnormal cases detected were 16. The heterogeneity calculated between the studies was only 23%, which mentions that it is a good study. There is no very less variance between the studies. So fixed FX model was used. the odds ratio was 0.28. If the odds ratio is more than 1, it indicates a significant association or a significant, it mentions that this test can significantly identify the anomalies. So coming to p-value, it was 0.22, which was again not significant. Coming to positive rate of karyotype in hyperechogenic kidneys, it was analyzed in 10 articles. 137 hyperechogenic kidney fetuses were involved. 16 cases turned out to be abnormal. The heterogeneity again was low, so fixed effects model was used. Again, the odds ratio was less than 1, 0.25, and the p-value was 0.20, which was not significant. Coming to positive rate of CMA in non-isolated hyperechogenic kidneys, 5 articles were analyzed, out of which 61 non-isolated hyperechogenic kidney fetuses were analyzed and 19 turned out to be abnormal. Heterogeneity was 0%. The odds ratio was 0.48, again indicating no strong association between the test and the anomaly, and p-value was 0.32, which was not significant. Coming to the positive rate of CMA in isolated hyperechogenic kidneys, the number of articles analyzed was 6. 120 fetuses were analyzed, out of which 33 turned out to be abnormal. The heterogeneity was 41%, which is moderate. So as it was less than 50%, the fixed effects model was used. Here the odds ratio is 1.46, which indicates that the CMA can significantly identify isolated hyperechogenic kidneys, but the p-value is 0.59, which is again not significant. Coming to positive rate of monogenic etiologies in the IHK, 147 cases of hyperechogenic kidneys was analyzed. So the number of abnormal cases turned out to be 77, but the heterogeneity was very high, 86%, and hence random effect model was used. The odds ratio was 0.80, close to 1, but it still doesn't give a strong association between the rate of monogenic etiologies in IH.
Okay, so let's focus on this column of 120 fetuses with isolated echogenic kidneys. When you do a CMA, okay, you expect about 1/4. You expect about 1/4 of them to show up something on the CMA, 1/4. Okay. And the chance that, so there should be something, no, when they say odds ratio, you are comparing with something else. Comparing with what?
Comparing with care.
CMA versus karyotype, is it?
CMA in IHK versus NIHK, sir.
With NHK. Is that what they are comparing? So we should know. So compared to the comparator, you have a 1.5 times chance of finding something. That is how it is. So you should tell us the comparator.
Yes,
Okay.
sir. Yes.
And if you keep repeating the experiment by drawing different sample, that means if they did, now we did, somebody else did, if you keep on repeating 100 times, 95 times it will fall within 1.33 to 1.62, which means all the time it's going to be more. CMA is going to yield more.
Yes, sir.
So no way this should be coming like this. Okay. So we should know what this says and what this says. The denominator we should know. Okay.
Yes,
With
sir.
what they are comparing.
Yes, sir.
That's why she sends the article so that everybody reads. This time I didn't read. I was traveling a lot, so I couldn't read. Right. Proceed. So no, whenever you talk about odds ratio, it's the ratio. So you should know the denominator with whom you are comparing. Compare to something else, CMA, performing CMA as a 1.5 times of detecting or hitting on a target. Understood?
So this is the detection of chromosomal and monogenic etiologies in isolated hyperechogenic and non-isolated hyperechogenic cases analyzed in the 21 studies. So now we will be analyzing the total number of cases identified. So, and we will compare it with the cohort study result. So the positive rate of karyotype in non-isolated hyperechogenic kidneys was 22% in cohort, whereas in meta-analysis also it was 22% and comparable. Coming to positive rate of karyotype in hyperechogenic kidneys, in cohort study it was 19%, and in meta-analysis it was 20%, which was again comparable. Coming to positive rate of CMA in non-isolated hyperechogenic kidneys, the cohort study it was 37%, and in meta-analysis it was 32%, somewhat comparable, but a bit lower in meta-analysis. Coming to the 32% results which they found in meta-analysis, they have also told that previous studies have shown the incidence of chromosomal abnormalities is 30% when multiple abnormalities are detected, and hence in NIHK by CMA 32% detection rate was there. Coming to positive rate of CMA in isolated hyperechogenic kidneys, 29% was detected in cohort study, and 59% was detected in meta-analysis, which is higher in meta-analysis. So the reasons given was that due to the limitation of years and detection methods, not all cases were tested for CMA and small sample size was used, which might lead to a false high positive rate. So high CMA positive rate in isolated hyperechogenic kidney may be because in later stages in third trimester or after birth, the fetus or baby might have developed additional abnormalities. Coming to positive rate of monogenic etiologies in IHK, in cohort study it was 100%, but in meta-analysis it was 31%, but both WES and targeted gene sequencing were used. So they concluded that compared to WES, when we use targeted gene sequencing, the detection rate may be reduced, and hence WES can be considered based on patient's indication like age factor or previous history, bilateral hyperechogenic kidneys with negative karyotype and CMA or CNV.
This explanation may not hold water here. Go back. Go back to that results table. The WES, yeah. Go back. So, yeah, hold on. Go back, yeah. PKHD1, PKD1, PKHD1, yeah, 1, 2, 3. Then next. PKHD1, next. That's all, no?
5 cases.
So the so-called WES still detected the renal genes only. They didn't find any exotic genes outside the panel. The panel would have still detected all these things. They had very few cases, and luckily they found something in the WES. Okay, if you expand the number of cases, WES, you will not be able to find out in bilateral echogenic kidneys all the time something abnormal, isn't it? Got it? Because if you go by their data 100%, you should never claim that, especially when the numbers are so small, like 4 or 5. What happens is then you will think that if I see bilateral echogenic kidneys, bilateral, and even if it is isolated, 100% they will have a single gene disorder. That kind of an information you will carry in your mind. That is not true. Understood?
So they also analyzed the proportions of the etiology in isolated hyperechogenic kidneys. The most common was HNF1B mutation. So that is 17.
Yeah,
that
it
is 17q to
Yeah,
1
it is
2 micro.
contained within the 17q microdeletion.
And the second one is autosomal recessive polycystic kidney disease. The third one was autosomal dominant polycystic kidney disease. And the fourth one was multicystic dysplastic kidney and Bardet-Biedl syndrome. The others included WTX variant, renal tubular disease, nephroblastoma, autosomal dominant Charcot, type 2 Imark syndrome, renal agenesis, and Beckwith-Weidman syndrome.
Go back. Proportion of deaths. So the most common is HNF1B, and that is contained in our 17q microdeletion. Vidya not there.
Sir, good morning, sir.
என்ன வித்யா உன்னோட டேட்டா வந்து இந்த லிஸ்ட்ல வந்திருக்கணும். தூங்கிட்டு. That's why you should publish your thesis before you become busy in your practice.
பண்ணிட்டேன் சார்.
சரி. Proceed.
So in this cases, they also found out that 23% of the cases of isolated hyperechogenic kidneys turned out to be normal. அடுத்து அந்த forest plot second class சொன்னீங்க sir.
Yeah. So I think the discussion would now move into a little bit of understanding of forest plot, which we will talk in a second session. Okay, all of you read about forest plots. When we do a meta-analysis, how is the pooled data presented? How is the pooled effect presented? How to interpret that? Okay, a little bit you read, then we will discuss and we'll understand in the class. Okay, any comments or questions? Escape. இந்த அளவுக்கு எஸ்கேப் பண்ண வேண்டாம். ஒண்ணுமே தெரியலப்பா. How can you be like that? I cannot see. Can anybody read? Systematic review and meta-analysis go hand in hand. Does one have edge over the other? When the data presented in the included studies are combinable from a statistical basis, you can choose to combine and present the pooled effect, like as though it's one effect. Then it's a meta-analysis. If it's not, if the results are not comparable, if the data that was the processes used to arrive at the results are also not comparable, then you can simply describe these studies. So 5 studies were in favor, 10 studies were not in favor. You cannot get a pooled effect, but you can still review all this one. So that is systematic review. So they do go hand in hand, and one extra step happens in meta-analysis. And of course, if you are able to do a meta-analysis, then you have a number in your hand to present. The pooled effect shows that it is 5 times more likely. So that number is there, and therefore there is a small edge. Fetus 22 weeks, isolated echogenic kidneys. Father 34 has echogenic kidneys. Can we take it as familiar, or should we do genetic testing? Possibility ADPKD. All right, ADPKD by the time the father is 34 may, but very unlikely to present as just echogenic kidneys. It is familial, but we should do a genetic testing is what I feel, and the father should receive a full evaluation of all the causes of adult echogenic kidneys, including genetic evaluation. Microarray 315K or 750K, Satya 315K. That is what we have decided. Anything not detected in that, we will escalate it to West then. Thank you. Mumbling.
Can you go ahead and do directly? Yes, because it's.
So the question is, if it is an isolated after your extensive and extended 2-sitting examination of the fetus, you find it is just isolated echogenic kidneys, can we skip everything and go to WES panel? So the answer is what? Better no, because we all know certain manifestations in a polymalformative association or a syndrome can present later. We may not be able to tell all at the same time. So it's better we go stepwise. Okay.
The question in isolated, you said CNV will be better.
Who told? No, if it's isolated, okay, your chance of getting a normal baby is much higher. That much only we can tell before we test. After we test and the tests are negative, then we can say now the chance of taking the baby home is much, much higher, close to 90 to 95%. You agree?
Yes.
Okay, so thank you all for signing in. Tomorrow we'll see tomorrow. Yes. Bye. Let me end.